we saw probably 50 patients today with melanoma, and they were all looking good. We hardly ever see recurrence. So today, believe it or not, today we had an optometrist who had a melanoma in her eye.
Oh, wow.
And I said to her, I said, gosh, if I could name for you all the people, optometry, ophthalmology, or ophthalmology nurse, ophthalmologist, who had something serious happen to them. But boy, what a scary thing to happen to you, right?
Welcome, everyone, to the very first episode of The Consult, Conversations with Medicine's Most Extraordinary Minds. I'm your host, Oam Patel, and I'm beyond excited to launch this podcast that dives deep into the stories, leadership, and legacies of healthcare's greatest heroes. Today, we're starting with someone truly legendary, Dr. Carol Shields. Recognized as one of the top ophthalmologists in the world, she's consistently ranked among the most powerful figures in eye care globally. Beyond her incredible accomplishments, she's also known for a little tradition. She wears green socks every Wednesday for good luck. And honestly, with a career like hers, I think those socks deserve a medal too. So without further ado, let's dive into The Consult with Dr. Carol Shields. Dr. Shields, thank you for being here today.
Thank you, Oam. Thanks for interviewing me.
Of course. It's my pleasure. So I think one of the most common questions that get asked to physicians is what kind of drew them to their specialty. But I want to ask you something a little bit different. Did you always know you were destined to be a leader, not in just ophthalmology, but as a world-class researcher and trailblazer who kind of built an entire subspecialty?
So I never saw myself as a leader. When I was in college and medical school, I seemed to blend in with the rest of the group, never saw myself as being a leader, and never had any maybe desire to be a leader. But one thing I know that I did, and which was probably a good thing, was I was a hard worker. So in college and in medical school, I worked really hard. And during my residency, I worked really hard while I was in residency because I wanted to really master the field of ophthalmology. I mean, I took notes, I would keep things organized, and I wanted to really understand all facets of ophthalmology.
That's amazing. And they always say hard work beats talent, so.
Yeah. That's one thing I have, dedication and hard work.
That's awesome. That's incredible. I want to have a little bit of fun with a rapid fire round I'll call Through the Lens. So how this will work is I'll give you two options and you choose your favorite out of the two. Quick instincts only.
Okay.
And feel free to elaborate on why you picked your answer if you truly feel passionate about one or the other. So,
okay.
Dr. Shields, are you ready?
I'm ready.
Okay. Retina or choroid? What's the better part of the eye for you?
Choroid.
Choroid. Okay.
Choroid, because that's where most of our tumors lie.
Right.
And I really have to know, in my field, the tumors from the non-tumors, the tumors from the hemorrhages, from the leiomyomas, from the hemangiomas, all the various manifestations of various tumors. Plus, I have to know all the imaging too. So that's why I chose choroid.
Choroid for sure. That's a good answer. What about OR at 6 a.m. or clinic at 6 p.m.?
Oh, that's easy. OR at 6 a.m. I'm a morning person. I like to get things done in the morning. I feel better during the day if I know I got something accomplished before I was involved in, say, patient care. And I don't like to stay late. I like to get home while the sun is still up because I really enjoy the outdoors.
That's awesome. What about, would you rather write a research paper or give a conference talk?
I probably would rather write a research paper. That would take a little bit more time. It's less creative, but it's more lasting. So a research paper gets put up on PubMed and it's lasting for years and years and years.
Right.
Whereas a conference talk can be more creative, little bit more fun, but it's usually 10 minutes or 15 minutes and it's one and done. It may not be remembered. So I like to do things that lead to a memory of some sort.
Right. Kind of creating that legacy of yours that you've already
Yeah.
well established. But I think I know the answer to this next one, but melanoma or retinoblastoma?
Well, that's a hard one for me because I enjoy managing both of them, but I seem to gravitate a little more towards the seriousness and what's on the line, what's at stake with a retinoblastoma child. So I know that I can handle a retinoblastoma child and possibly, well, I know I can save their life with whatever treatment I would choose, but possibly you have this chance that you might be able to save vision. So I really like the challenge of retinoblastoma, but I also like melanoma, but I would have to choose retinoblastoma.
Got it. Got it.
Is that what you were thinking?
That is what I was thinking, because
Okay, good.
I want to talk from you, and you were saying that your heart lies in retinoblastoma, considering this was from a while ago, but that's
Yeah.
awesome. Now, probably the most important of them all, basketball or tennis?
Oh, geez. Easy. Basketball, easy.
Good.
And it's because I was raised in a family of 8 kids.
Mhm.
I had 5 brothers,
Mhm.
and back in the day, in the 70s and 60s, all we had was basketball or bikes. And I played a lot of basketball. I developed a jump shot, a drive. I was really good left hand, right hand.
Mhm.
And I love that sport. I love that sport. But tennis, I've kind of gone a little bit towards tennis more recently. But, tennis, if you start in your 30s,
Mhm.
you never quite get the top spin the way you would have gotten it had you started when you were 5.
Mhm. Sure. Have you looked into pickleball at all? I
Oh,
recently
yeah.
went
I
pickleball.
play a lot of pickleball.
Yeah.
I enjoy it. Pickleball, I don't take too seriously, but it is a great sport and it's a lot of fun. And it sort of takes all the best aspects of tennis into pickleball. So you can laugh the whole time you're playing, and you have, you stay out of the kitchen, and, you want to make a drop shot, and a lot of fun things that you can do with tennis, but it's much more forgiving.
True. Very true. I see everybody comes together at the community park to play pickleball. Everybody,
Yeah.
all ages. So it's really
Yeah.
nice. Okay, Dr. Shiz, that was very insightful. That was very fun. Now I want to get a little bit into your clinical insights. So something that amazes me about your career is your balance. It's the balance between precision and science paired with that deep humanity. You've seen over and taken care of over 100,000 patients. Now that's not just data, but that's 100,000 different human stories. Is there one particular story or a story that you can remember that stands out, not for rarity, but for a deep human impact?
Yeah. There are several, but one that really stands out was a young boy that we saw from the country of Panama. And in his country, he had retinoblastoma in both eyes. And in his country, the only thing they could do was remove both eyes.
Mm.
And somehow, I don't know how, he made it up to our clinic. And I took a look at him and I said, no, you don't need your eyes removed. And we treated him with systemic chemotherapy and saved both eyes. And I do think we got vision in one eye. I'll never forget this young boy. But we have many, many kids like that. We had a kid recently, a child from Guatemala, who had one eye removed in Guatemala for retinoblastoma, and the other eye had already seen chemotherapy, intra-arterial chemotherapy and intravenous chemotherapy, and his tumor was still growing. And I took a look at him and I said, one thing we can do, and it's not going to take long, is we can put a plaque on this eye, eradicate the tumor, and save him all the chemotherapies. and we put a plaque on. We saw him back. He looked great. So the tumor responded to one plaque treatment, whereas it wasn't responding to multiple intraarterial chemotherapies. And sometimes when they do intraarterial chemotherapy in other centers, blood vessels get clogged or sclerosed, and you can't get the chemo in. And I think that's what probably happened to him.
Wow.
So that's when plaque radiation becomes important. And this was a child that we just saw this year.
That's incredible.
Yeah. So it's really exciting when we can diagnose and make a judgment for a therapy that might be curative for a child who's been through so much.
Right. Yeah, 100%. I think one of the things that leads to being able to help somebody so much is that early detection aspect of it. I know you mentioned like transforming imaging. Imaging is a huge thing.
Huge.
And I think one of the questions that I wanted to ask you, what's your go-to diagnostic tool and why?
I love wide angle imaging. We use Claris imaging, and I have no financial interest in Zeiss. I love our Claris because the color is almost real. A lot of retina people will use Optos, but it's unreal color. It's artificial color. So I like wide angle imaging of the fundus. But if I had to choose from a second imaging technique, I think OCT is really transformational in explaining to us why patients have mild vision loss or moderate vision loss. We can look at the anatomy on OCT and make a judgment on why they might have vision loss. It's a really important tool.
That's awesome. I think in the charts that I've reviewed, OCT is one of the quickest things that I can look at and to tell something from it. So that's amazing.
Yeah, it's wonderful. But in ocular oncology, ultrasound's also very important. Anything that we see that's acoustically hollow in the choroid, we worry about melanoma. If it's acoustically dense in the choroid, it could be one of many things. It could still be melanoma. It could be a nevus, could be hemangioma, could be metastasis, could be hemorrhage. So there's a lot of different things. So when we assess a patient, we're putting together all the imaging to make an accurate assessment.
That's good. I feel like that comprehensive nature is what makes like the diagnosis so accurate, the treatment plan so accurate. So that's incredible. That's good to hear. I think one of the things that I wanted to move on to is mentorship. You've shaped the careers of hundreds of future leaders. And when they describe being mentored by Dr. Carol Shield, words like sharp, disciplined, kind, visionary come up. What's your approach to mentorship, and what qualities do you look for in those that you choose to guide?
We mentor a lot of medical students each year, and I do think it's important for them to see the ocular oncology side of ophthalmology, because if they're only exposed to the refraction or the cataract side, they're missing out on a lot of the medical conditions that can be very important and can be life-threatening. So we like having them so they can see, just even if they remember one day of seeing a patient with a tumor and how that impacted their life. It's a little bit more of general medicine plus a little bit of psychology and a lot of imaging. When we mentor people, I like to treat them like they're doctors, like they're my colleagues, like we're on the same level. And I want them to learn as much and maybe as efficiently as possible. So they'll see things with me repetitively, and hopefully that will sink in. We take fellows, we take residents, we take medical students, and everyone's on kind of a different level. So you have to kind of gauge the way you talk to each of the mentees, which level they're on.
Right.
So I mentor people so that they can understand what ocular oncology is about. And, usually when they finish their rotation with us, I always say to them, and I'll say this to you, You've seen like the hard side of ophthalmology. This is very challenging, potentially life-threatening, no wiggle room. You got to be accurate. There's no estimation. Everything is measured. And it's very important that you have discipline when you go through ocular oncology if you want to have good outcomes.
Right. I can definitely say I saw that today, and if it means anything, I definitely will remember today. For a long, long time. So
Yeah. So where did you spend your day today?
today I spend it actually throughout the clinic. I went to photography. I did visual acuity. I did visual field. I went to ultrasound, but I think that those four were the primary areas that I was in.
Okay. Good.
Yeah, it was very nice.
You saw Jeanette doing ultrasound. She's very good.
Yeah,
Mhm.
very, very, very good.
Mhm.
I think one of the things that leads me to is your legacy. When you think about it beyond research, what do you hope will be remembered the most?
So, I mean, I'll say in my career, I hope the patients appreciate the time and effort that we put into each and everyone's care.
Mhm.
So I hope they're appreciative of all the time and effort that we have given to each and every one of them. In my life, I hope my legacy will be that her life was dedicated to helping others. Starting at 5 a.m. till she went to bed.
Yep.
Yeah, and it's helping others not just in in the clinic or in the OR, but just helping others, even if it's helping the next door neighbor or cutting the grass for one of my kids, or just I just gave of myself to others.
Right.
Yeah.
That's
The last person I take care of is myself. I figure I can go with little need.
Mhm.
And that's why when my husband Jerry was here,
Mhm.
I took care of him every day for 40 years. I did everything I could to make his life as easy as possible.
That's amazing. That's amazing.
Yeah.
Life is definitely about, that sacrifice, but medicine itself is one of the
Yeah.
biggest sacrifices that you can give. I think specifically in what you do that I really appreciate is you're not only sacrificing to save somebody's life, but you're also preserving one of the most important things in their life, which is their vision, their ability to just go about and see things.
Yeah.
Just incredible.
Yeah. With nearly every patient that we counsel, I always say to them when I'm counseling them, the first thing we have to consider is we want to do what's number one, safe for your life.
Yep.
Then number two, safe for your eye. Then number three, safe for your vision. So we're balancing all these three things. I don't think there's any other field in ophthalmology that has to balance three things. Cataract surgery, you're balancing mostly vision. Uveitis, you're balancing the eye with vision, not necessarily the life. But we have to make a decision. I had a young girl in from Minnesota today who had a malignant tumor in her eye. It wasn't retinoblastoma. And I had to convince her parents that eye removal was the best for her life. And I have to do that every week, and I usually get pushback from parents like,
Sure.
can't you do something to save the eye? Why do we have to remove the eye? But I have to tell them this in this day and age in 2025, removal of the eye is the safest thing you can do for your child. Because if you do anything less, your child's going to be dealing with problems the rest of their life.
Right.
Yeah.
That makes sense. I think balancing that emotional aspect of the parents with the experience and logic that you've built up is definitely very commendable that you have to do that on a daily basis.
Yeah.
I think.
Yeah. And, even today, when today was a follow-up day, we saw a lot of patients we operated on with conjunctival melanoma, uveal melanoma, squamous cell carcinoma. And they all, actually, almost all the patients looked excellent. And I think they're very happy when they hear us say that.
Mhm.
And many of them who I think probably feared losing vision, conjunctival melanoma, and they come back with 20/20 vision, they can't believe they're actually seeing with that eye.
Right.
And, it's very satisfying on follow-up days to see the patient outcomes.
Yes, true. I haven't even been there at the beginning, but when I was doing visual acuities today and people were able to see, it made me happy because they were diagnosed with something so, prominent, but they're still able to see, some of them even better than me without glasses.
Yeah, right. You couldn't read the lowest line, but they
Yeah.
could. Yeah, that's good.
Yep.
Yeah.
Very good. Final question for you, Dr. Shields.
Yeah.
For those just starting out, the overwhelmed first-year medical student, what advice would you give?
So when you start in ophthalmology, you want to be an ophthalmologist.
Mhm.
You want to learn it all. You want to learn cataract surgery, retinal detachment surgery, refractive surgery, how to handle a wrist drop with glasses in the clinic. You want to learn it all. You want to be there. You will learn it all as you go through your 4 years of residency. But once you get out into your field, whatever your field might be, it's always nice to have a little niche, like something you're known for. Like, oh, if you can't get glasses, he's the guy you send your patient to because he always makes the glasses perfect. Or, like us, if you think there's a tumor or a freckle or a nevus, send it to us and we'll take a look because that's our niche. We know how to judge these lesions. Or if there's something that looks like an ulcer, you're going to send it to someone in cornea because they always see your ulcers. That's why I think a niche is very important once you get out and really develop that niche so you become well known for it. But when you're in residency, you just basically, you learn it all and then you kind of focus in on what really drives you. If you love cornea, maybe you're the DSEC guy. You do all the endothelial grafts and you become so excellent at that. And people will recognize that. Yeah.
That's very
all very interesting. So in our field, ocular oncology, I've kind of made my little niche, retinoblastoma.
Mhm.
And my second niche, I love conjunctival tumors and I also love taking care of the uveal melanoma. That leaves a lot untouched. That
Right.
leaves eyelid tumors untouched, orbital tumors untouched. And we have others who have that as their niche.
Right.
So they handle those and they handle them, frankly, I think, as well or better than I could have handled them. So I give them credit for what they're doing. And the other thing, when you're in especially a referral practice, you want to be sure you always give credit back to the doctor who recognized something was wrong, possible tumor, and sent the patient to you. Or if you're in cornea, something wrong with a cornea, and they picked up the phone and sent the patient to you. I always say to our patients, Dr. So-and-so detected this early, or thank God Dr. So-and-so sent you to us without touching this.
Mhm.
Or, boy, did they do good cataract surgery. I'm glad they sent you to us. Just so they feel good about their referring doctor, so they'll want to go back to them. Because when you're in an ivory tower like we are, patients are just going to want to come back here and just be seen here. But you really want them to want to see their regular doctor too, who did a very good job. They may go another 15 years before they see another melanoma in the eye, but
Sure.
give them credit for what they saw. Even if they got the diagnosis wrong, at least they saw something was wrong with that eye.
Right.
Yeah.
Amazing advice.
Yeah, it's good advice.
Create your niche, remain humble, give credit
Yeah.
do, and strive to be the best at those three
Yeah.
things. I've been keeping notes.
Okay, good. You're
But
going to do well. I think you've got a great attitude, and you seem to have a happy affect, and that's going to go a very long way.
that means so much coming from you. I really,
Yeah.
really appreciate it. This
Okay.
has been an absolute honor. Thank you so much. For even inviting me and welcoming me to your team for
Yeah.
this.
Sounds good. Thank you, Oam. It's wonderful to talk with you, and I hope to see you in the operating room.
Yes, I will be there on Thursday.
Okay, good. See you then.
See you again. Bye.
Bye-bye.